Hi, this is Susan Blakeman talking to you about using the psychiatric evaluation report outline. This is a very brief tutorial to this outline, and the purpose is to help you use this tool to your best advantage throughout your curriculum. You will be seeing it in several places, and it's important that you understand how it is to be most effective. Walking through the report outline, you will find that this is very similar to any type of organized psychiatric evaluation. You will see slight variations in your textbooks, but all psychiatric evaluations follow the same basic outline. The first is to start with identifying information, and this is really to say what is important about this person that you need to know. What are some of the important features, age, date of birth, gender, for example, or how people identify their own gender, where do they live, what kind of things are they involved with, and who are they there with, and why did they come to see you today. So that's usually an opening. Chief complaint. This is really what the patient says is the reason that brought them there today, and sometimes that is very consistent with what you find as the clinician, and sometimes that can be very different. But starting with what the patient wants you to know is very important. Usually this is a quote. History of presenting problem. This is meant to be a very succinct summary of what got the patient to see you at this point. So what does the patient understand as what's happening, the problem? What are the precipitating events? This is not a place to put a lot of detailed past history. You will have an opportunity to do that later on. You really just want to relate the history to what is happening today. And important also to not repeat yourself too much within the evaluation. Okay, you want to keep this succinct because you want people to be able to read fairly quickly and understand what you have to say about the patient. Within each of these categories, you are going to see several sort of prompts for questions that you might ask that might be pertinent. Not all questions are going to be appropriate to every section for every patient. We'll continue to talk about this as we go on. On this particular form, where you see things highlighted in yellow, these things are particularly important for you when you are taking your Nursing 452 class. That will become clearer as you go along. But there is a specific focus on neurocognitive assessment that needs to be captured in a general psychiatric evaluation as well. Okay, so in the next section, these are sort of combined together. You might see these separated in other formats, patient psychiatric and medical history. So this is the details. You know, when has this person had psychiatric problems before? When have they had treatment before? How did that work before? What were the dates of that? How long ago was it before they presented to you? What is happening now? Are they not in treatment now, or is treatment not effective for them now? This also gives you a sense of the level of severity of their illness. How many times have they been hospitalized, if at all? How often did they use the emergency room? What is their suicide history? Have they made attempts or gestures? What else is going on? And you might have to probe a little bit to find this out, and you may get some of this information from collateral information from whoever came in with them, or certainly a parent, if that is a possibility for a child, or a spouse, or from a medical record, or from another provider. Not all information is going to come from the patient, and you need to gauge carefully what you are asking to do a thorough psychiatric evaluation versus what is going to be too stressful to the patient. But these are very important details. The medical history is also very important. You are always going to be thinking about what is your differential diagnosis, and often As you know, psychiatric symptoms can be very similar to medical, physical illness symptoms and contribute, vice versa. So you want to know their general health, particularly of a child. When have they been seen? Are they getting regular care? Do they have immunizations, a flu shot, things like that? What is their history of infection? Could they be having an infection now? You certainly want to know things hepatitis, because that gives you a lot of clues, but also you want to be knowing things about liver and kidney function if you're going to be prescribing treatment. You always want to be ruling out possibilities for delirium and just knowing, about their hospitalization and surgeries. And again, putting on that detective hat. Could it be a child was in the hospital because there's abusive history? Or is somebody having difficulty ambulating, falling because they're using substances in addition to any other number of things? You also want to know, has there been cognitive impairment, brain injury, seizures? There's also this functional assessment that you see. How well are people functioning in their day-to-day life? How does that relate to their health and wellness, and their ability to be able to give you accurate information perhaps and be able to follow a treatment plan? Sexual development and history is also important. We want to know where people are on their continuum. What is their concern? Certainly want to know if people are having hormonal changes, for example. And development, of course, is very important. You also want to know, around people's sexual orientation and identity. Those might be things that are of issue to folks, and we want to be respectful for them and thinking about them. We want to know if folks are being in coercive relationships, particularly when you're dealing with younger patients. And certainly you're going to be thinking about pregnancy if you're going to be prescribing or doing any treatments. Substance use is very important. You want to be discerning what is current, what is past, and what things to be looking out for. And in substances, you also want to be paying attention to not only street drugs, but prescription uses, non-prescription medications, caffeine, tobacco, and anything else that might interfere or add to your diagnosis, your assessment and diagnosis of this patient. Abuse, again, we sort of picked up that in sexual development, but that is very important. Also physical abuse. And don't forget that this can happen at any age, and we need to be paying attention and wondering what has happened and what is people's experience with providers in the past. So these are other habits that are very important to be considering as you're wondering, again, wellness in life and what is perhaps getting in the way. What addictive tendencies they have? Are they giving you clues to bipolar symptoms also? And their health beliefs and practices. So we want to be respectful and know where people are in terms of their understanding of their physical and psychiatric health, and how we can engage with them around best practice, and whether or not they're having adequate nutrition. Of course, that's really important too. And their sensory needs are also something you'd want to pay attention to. Again, you might not get through all of these things for all people, but you're going to be assessing from the moment you see someone. So not all of these also are questions that you're asking, but you're going to be paying attention, for example, to sensory needs. Are they wearing glasses? Do they have a hearing aid? Do they seem to be understanding you? What is their gait like? Do they have an assistive device? That's part of what you're going to assess without having to ask them specific questions. Okay. Medications. These again are very important. You really want a pretty detailed history to the extent that you can derive it. You want to check accuracy with your collateral sources. You want to know about medical medications as well as psychotropic medications, and it's also helpful to know sort of a timeline. When Okay, when were you last on Prozac? How did that work for you? When did you stop it? Who stopped it? Did you stop it or did the physician stop it? Tell me more about how that happened. What do you think about that? Whether it was or not it was effective. Types of medications will also sort of give you a sense of what symptoms they've experienced in the past too, based on what has been prescribed. And never leave out supplements, over-the-counter, complementary and alternative medicines, because those can be very important in discerning what patients are using, what they're comfortable with, what they're not, and what might interfere with your plan of care or interact with your plan of care. Family, medical, and psychiatric history. Again, this is important to know because you want to know about risk factors in the family. You want to know not only is there a genetic risk for, say, depression, anxiety, or psychosis, but whether or not that might have had an impact on how people have been raised and nurtured, what their family life is like. Is it chaotic? Are they getting the attention and care that they need? So you want to know both on both sides of the family. You want to know about suicide in the family and how people understand that. That's, important for them, thinking about their own safety and whether or not this is accepted, whether it's taboo, whether it has implications within the family. You also want to know a little bit about family legal problems, because that also can be related to a lot of psychiatric issues, whether or not somebody was incarcerated because they were using substances and stealing, or were manic and prostituting, or they have some antisocial kinds of difficulties, and it speaks to the family constellation. Substance and alcohol we talked about, and personality traits, kind of getting a sense of like what is the configuration of the family, as well as the medical risks to be thinking about too. These are always very, very important. So this sort of goes back with the some of the medical things have some overlap with developmental and psychosocial history. You want to be careful to sort of sort those out in your mind. So if you can put on sort of your medical nursing hat when you're sort of reporting on the psychiatric and medical history for both the individual patient and the family. Again, those are separated into two columns. And then think, what are the more social aspects of that? Again, what you want to be doing is not repeating yourself in a lot of places. So half of the challenge is figuring out what goes in each section and how to tell a story parsimoniously. Okay, so you might get some answers to your questions in earlier sections, but you want to report on them where they make most sense in terms of what is the happening for this patient that is helping you build an assessment and a diagnosis. So these are the other social important things for you to be thinking about. Parents and occupations. Again, you are going to ask, some of these questions are going to be more relevant depending on the age and the situation of your patient. So if you're seeing somebody who's an older adult, this might not be the first line of questioning, but when you're seeing a teenager, you might want to be knowing, what's happening for your folks. Is your mom or dad out of work? Are they home? Are you home alone after school? What's your relationship with your siblings? So some of these things, again, will have more relevance for patients than others, and you don't want to get tripped up. You don't want to miss data that are important, but you don't want to spend time on data that really aren't helping you with your assessment. And again, and these are here for you to sort of think of what might be important for this family. Of course, support is always important for anybody, and that may come from a biological family or elsewhere. Okay, and of course, language, culture is important, and we'll get to that. Pregnancy, gestation, delivery, important to know that when someone is in utero, it is their gestation, it is not their pregnancy, but a female might have a pregnancy and might describe that pregnancy in reference to the child. It's important sometimes to know, if the mom's talking about difficulties with the child, was this a child wanted? Was this a difficult pregnancy? Do you have a sense that this kid was always difficult? As well as knowing about prenatal exposures, which will have indications for development, as well the APGAR, the birth weight, these are was the child to term. You probably are less likely to ask these questions out of the gate for an adult patient, but if you're having some thoughts about, boy, what is this cognitive history over time? Is there something that happened early on that might be helpful to know about? Then you might want to go there. Again, picking your questions carefully. Very important. Temperament, particularly with younger children. Okay, and development, we want to know about that for anyone. Again, developmental milestones, think about when that is important. You also want to think about, you might have somebody with schizophrenia, and we know that there are early sort of signs about that. How did they do in school? Were they kind of a loner? Did they have social relationships? Did they have activities or anxiety? There are prodromal symptoms or clues across the lifespan that sort of might point you in one direction or another. And there's opportunities for misdiagnosis. We have plenty of adults being diagnosed with ADHD, but maybe just never got caught in school. So that sort of can fit into the history that you want to be understanding their social development. Again, friendships, relationships are really important. We think of the character pathologies as well. What are the dynamics of relationships are important even later in life than particularly early in life. Again, educational, occupational history, how is that going for you? What do we need to know? Military is very important, not only for a sense of an occupation and skills learned, but also was their trauma experienced? Have people been able to hold a job or do well in school? And is it different how folks are experiencing symptoms in one setting versus another? You're always thinking about that. So this kind of information is important across the lifespan. The person's own legal history is very important. And let's not forget things like risk-taking, driving a car really fast, shoplifting, fire setting. Did they get caught or not get caught might have legal implications, but also what are those behaviors like that could put you on the edge? Most significant things, this is just a way of sort of getting more out of somebody. Tell me about when things were great. Tell me about when things were not. And you get a sense of a timeline and how the person tells their own story. And that's part of this. This is particularly helpful when, you're sort of not quite getting the information you want, or people are having a hard time with sharing facts with you, or you're not so sure about the accuracy of the historical information. Kind of bringing it back to the current gives you a lot of insight as to how the person is functioning in their relationships and in their own interests and their sense of identity also. So mental status examination should be getting over time clearer and clearer for you. This is a pretty straightforward aspect of the evaluation, very, very important. But again, you want to be really noting what people look like from the beginning. It gives you a lot of clues. Is there anything that looks like it might be odd in terms of their development or their physical features that might point you to a medical issue or developmental issue? Do they have adequate nutrition? Secondary sex characteristics, this is about development, of course. Are they steady with their gait? What kind of dress do they have? Is it appropriate for the climate and the occasion? Is it odd? Is it eccentric? Is it provocative? Is it clean? And I, working in emergency for a lot of rooms, I always sort of do a brief description of the clothing because you never know if somebody's going to walk out on you and you're going to want to find them if you have concerns. Again, what else is happening in terms of their, just a way of describing them and whether or not you think that they're able to take care of themselves, really. Eye contact, again, different components might tell you different things. If they're staring at you, or they look like they might be intoxicated, or they look like they might be trauma, they might look like they're responding to internal stimuli. Level of activity, manner of relating, how comfortable is this interaction? How awkward is it? How guarded are they? Are they paranoid, for example? Mood is a quote. You want to ask somebody to describe their mood, to rate their mood. Are they depressed? Are they sad? You want to go, if 0 was really terrible and 10 was the best you've ever felt, where are you on that scale? Give me a sense of that. And then affect is the expression of mood. That is what you are watching, what you are seeing. Do they have a range? Is it appropriate? Is it congruent to what they're saying? Are they, saying they feel very anxious, but they're not looking like that at all, or they're laughing when they're saying they're very depressed? What is that about? This is, again, part of a formal assessment of speech language that you will get many more details about how to perform, specifically in 452. But these are the components that you want to be sure that you're hitting on. For a general assessment, you want to just say, what is their rate and rhythm? What is their inflection, their tone? Are they having difficulty getting their words out or finding words? Is there anything odd about their speech? Is that repetitive, stuttering? Just gives you different senses of what someone's cognitive functioning is, as well as their education and intellect, as whether or not they're responding to internal stimuli, or they're having, some level of impairment or intoxication. There are 2 points to the thought process, or thinking. There's thought process, and then there's content and themes. So these are the things that you want to be thinking about in terms of thought process. Is somebody sort of linear in their thinking, that's goal directed? They can start with a thought and finish a thought, or are things getting in their way? Are they having a hard time sticking with something, or are they can only stick with something? They're perseverative, or the thoughts are coming in too quickly and they can't make much sense of them, or they're just kind of going around and round, or going off on tangents. That's very important. And then the content. What is the theme? What is the sort of what they're really wanting you to know, as well as, do they have any suicidal ideation, or have they had any gestures or behaviors? Again, this is a time, if you haven't caught it before, you want to think about, has it happened in the past, and how recent of the past? What's happening now? Does it come with a tent? And what is their plan? You want to ask about a plan. To what extent have you thought about overdosing on pills, or crashing your car, or hanging yourself, or using a gun? Do you have a gun? Do you know how to use a gun? Do you have bullets? So depending on how that works, in terms of your patient's report, what are the questions you're going to ask? You really want to be careful here. And what is keeping you from acting on that plan? What would change that would make you act on that plan? Are you thinking about hurting anyone else? Delusions. Okay, are there things that are happening that do not seem quite to match with reality? That's what you're trying to determine. And then, sort of this fantasies. So what else is happening? Like, what are the conflicts of somebody or distortions that they're presenting to you? Perceptions, this is hallucinations of all types, auditory, visual, any senses, olfactory, gustatory, illusions, the sense of depersonalization, all important to sort of inquire about, particularly if you're getting some signs. You want to be asking more specifically about that. Cognitive orientation, do they know where they are, who they are, what's happening, time, date, anything in the current events, and how are they doing with their memory, immediate and remote, and ability to learn. And these are ways that you can assess that. Also, and this is part of a more formal assessment, but if you have suspicion, particularly if somebody is having any deficits in these areas, you want to get out the tools. You want to be more intentional about how you're asking things, and you may want to be doing, for example, a mini mental status exam, or one of the other types of exam slums that is going to get you more particular detail. Intelligence, this is sort of something you want to comment on because you want to have a sense of, how they're processing information. And again, this is attention and concentration. This is very detailed in terms of the formal assessment for 452. But in general, you might be asking about serial sevens, or being able to spell rolled forward and backwards, and recalling numbers. Higher cognitive function, again, there's very formal assessment of that. I won't get into all of those details, but you often are wanting to get a sense of how people are doing. And proverb interpretation is one thing that you'll see fairly consistently on examinations, to get sense of people's ability to be abstract versus concrete in their thinking. Okay, I'm going to go through this a little bit. And judgment is insight. Judgment is, let's start with insight actually. Insight is the ability to understand what is happening for them, what are the precipitants of their struggles, the severity of their struggles, understanding their own role, what they might need for help. And judgment is what they might do about it, the ability to be safe, the ability to come in for treatment. So you want to assess that carefully. And then if you're going to do symptom rating scales, those are a very important tool for your assessment as well, and that's something we will get into it at other times. The diagnostic formulation, I'm going to give you a separate presentation on that. There's a PowerPoint in Nursing 450, and I think in 452 about it, the same PowerPoint, and I will voice over that so that we can help you. But basically the purpose of the diagnostic formulation is to take everything that the patient is saying to you, everything that is in their history, and everything that you are observing, and think about that theoretically and developmentally, and what are the pieces of that that are pointing you towards a specific diagnosis. How does that align with the DSM-5, the criteria for the diagnosis, and what do you think about treatment, or what else do you need to know? What do you need to rule out? What have you ruled out, and what do you need to rule out in order to get at a more specific diagnosis and plan? Your diagnostic impressions fall from the DSM, and your treatment recommendations are really about, so you think this is, you're thinking about it, this is what it is, and based on all of this, this is what you want to do. And part of that plan might be that you need to get more information. You might not have gotten all of it all at one shot, and that might be important in order to move forward. So that is your fairly brief overview of the psychiatric evaluation report. You will be seeing it and talking about it in all of your courses pretty much. And if you have any questions, please ask any of your faculty. Again, it is a tool for you. It is prompting for you. It is for you to use to the to the best of your ability in evaluating people, but your patients, but in no ways does it mean that you have to ask every person every question every time. Okay, thanks for listening. Talk to you again soon.